All right, so we are recording. Looks like we are good to go. If you guys can hear me and see me, just type something in the chat conversation that so I know that everything's coming through on your end, and we will start. Awesome, thank you. Great. Thank you, guys. Okay, we'll go ahead and get started. So the last couple times we met, we talked mainly about using assessments, also doing case conceptualizations, and diagnosis. Again, these are skills you're going to continue working on throughout your career, and this is more of just kind of a crash course and a help for what you're doing right now. And so obviously the very next part of this whole process is to develop a treatment plan. And for kicks and giggles, I like to use visuals with this. So I'm gonna open up a screen here. Let me see. Share a window. Nope. All right. All right, so here it goes. So please do not judge me on my lack of graphic artistry or skills. They're not there. Not at all. So just an idea of how to think and how to conceptualize a treatment plan. So we're going to use the same client that we've talked about the past couple times we've met. It's that individual who came into the office because of post-traumatic stress disorder. We talked in the last sessions what the symptoms were, how long they'd been present, as well as other issues that were also there. Now it's time to actually build the treatment plan and to decide what exactly is going to address the issues. I like the idea of a house, of using a visual of a house for treatment planning, where the foundation of the whole thing, as it is down here, is the diagnosis. If you don't build your treatment plan on a correct diagnosis, your treatment is not going to function. And that's just kind of how it goes. It happens sometimes. In fact, sometimes somebody's misdiagnosed, not necessarily because of you, but because they did not fully give all the information. That can happen occasionally, but for the most part, it doesn't. And so if you have a solid foundational idea of what is going on with this client, such as we do with the individual we've been working on, then we can move forward. And so with a house, you've got first off this whole idea of how you want the house to be. The truth of the matter is we may have an idea with the client of how we'd like to see treatment end, but they need to have an idea. Because ultimately, as it says up here at the top, the finished home, long-term goals, it's theirs. They're the ones with the issues, not us. And they're there to try to figure things out. And what we have are tools and parts of the house. So with the short-term goals, a house is made up of many different things. It's made up of the different lumber, it's made up of framing, it's made up of sheetrock, it's made up of the foundation, concrete, and all the plumbing, electricity, and everything else. Every one of those things is a short-term goal that has to be built one upon the other until you finally have a functional home. And the tools we use, I put just here, hammer, air tools, square, carpenter square, those are the interventions and methods. So again, this is just something fun that I attempted to draw. I don't even remember what app I used, but it kind of looks okay. So using that idea, what we're going to do also is, rather than just pull something out of the air when it comes to treatment planning and interventions, I actually want to share a resource with you guys. Now, by no means am I endorsing this specific resource. There's many of them out there, but this is just one that I have sitting around. And this right here, it is called the Complete Adult Psychotherapy Treatment Planner. There's probably about a dozen of these out there if you look on Amazon and things like that. But this one's really great just because it's general. Like I said, that's what it's called. Complete Adult Psychotherapy Treatment Planner. I think I picked this up several years ago, probably 10 or 11 years ago. and I used it for quite some time until I finally no longer needed it. But it was great when I got my start. The reason this is nice is all the chapters are according to whatever the disorder is. And so before we started, I went ahead and I already checked into the post-traumatic stress disorder chapter to make sure that I really liked what was here. So before we go into what this kind of gives us an idea of when it comes to interventions, remember we're working with a roughly 52-year-old male who went through a severe trauma, found his son, you guys remember the story, who had passed away on site at work due to an industrial accident, that he was the one to find him. He performed CPR, and after that he began to experience all of the post-traumatic stress disorder symptoms. He's struggling with feeling down and depressed a lot. He's had problems so significant that he cannot return to his prior job, so he's working for temp agencies, and he's just really not functioning very well. And so his goal is, long-term goal, or his house, is I'd like to get back to how it used to be. Well, the truth is, and you and I all know this, an individual can never return to exactly what they were before, because developmentally that just doesn't happen. We continue to progress. And so it's helping him to figure out what he wants in the future. And so you work on that with him, and then figure out the treatment plan and the interventions. So here's the fun thing. In this chapter, it actually breaks everything down into long-term goals, or the finished house, as well as short-term objectives. And that's exactly what we're looking for. We're looking for this long idea out in the future of how things are going to be and the steps to achieve them. So here's some examples. And again, by no means am I endorsing this. I am just saying this is an example. Long-term goals: reduce the negative impact that the traumatic event has had on many aspects of the client's life and return to the pre-trauma level of functioning. That's just fancy words for I want to get back to feeling how I used to feel, just like the client said. Another one, recall the traumatic event without becoming overwhelmed with negative emotions. That is a very common symptom and problem with PTSD. And then finally, another one, terminate the destructive behaviors that serve to maintain escape and denial while implementing behaviors that promote healing, acceptance of the past events, and responsible living. And there's a few other long-term goals. So again, those are the long-term full house idea of what the client wants to get to. Now, the short-term goals, and there's many possibilities, but I'm going to go over a few of these. Let's see the first one. Identify the symptoms of PTSD that have caused distress and impaired functioning. The reason that is helpful is it helps a person gain awareness of what is going on. The thing about post-traumatic stress disorder, it is not fully like a let's say mental aspect or just a cognitive aspect that the individual is experiencing. It's not something that, like, let's say cognitive behavioral theory can fully touch on, because there's so much biology in it. When an individual experiences trauma, the fight or flight centers in the brain, they get triggered. And if the trauma is strong enough, and it's triggered very strong, those centers of the brain stay on, because what it's doing is it's trying to keep the person safe. And if that is being consistently turned on or triggered, or whatever word you want to use to describe it, their capacity to think through things is diminished, because the part of the brain that is involved with logically thinking through and processing information is somewhat dormant. And as that continues to progress, then their emotions continue to become even more difficult to manage. And so helping them to identify it can help to try to wake up that part of their brain. And so that's just the objective. Now, the interventions. Here's a couple examples. Ask the client to identify how the traumatic event has negatively impacted his or her personality relationships, functioning at work or school, and social or recreational life. So that is a specific topic of conversation you'll be having with the client. That's the intervention. That's the work that's going on. Another one, ask the client to list and then rank order of the strength of his or her symptoms of post-traumatic stress disorder. So this is something you could do in just one session. And again, what it's doing is trying to wake up that part of their mind and their ability to function. Another short-term goal, and this is a hard one, describe the traumatic event in as much detail as possible. Now, as somebody with post-traumatic stress disorder, I would not likely have them do that in the first few sessions. If they're in the middle of that trauma still, let's say, reliving it over and over in their mind, then the first thing we have to do is help them to feel comfortable and safe so that they're able to recount it and not decompensate right then and there in your office. Because if that happens, then it's your job as the therapist is no longer to help them work through the trauma, it's to help them work through the discomfort in that moment. And so what I would do is I'd set another goal, and that goal would be to learn how to deal with and function when difficult emotions arise. And interventions, there's lots of them. It could be mindfulness meditation. It could be relaxation. It could be breathing. It could be other types of physical activities that help them to feel in control. So, but going back to describing the traumatic event, here are some of the interventions it says, and I'll go further into that. Gently and sensitively explore the client's recollection of the facts of the traumatic incident, as well as explore the client's emotional reaction at the time of the trauma. Now, I'd add to that. I mean, again, this is just an idea to get to start. When it comes to treatment methodologies with post-traumatic stress disorder, there are many. You've probably heard of eye movement desensitization and reprocessing, or EMDR, trauma-focused cognitive behavioral therapy, or TFCBT. There's even trauma-focused mindfulness approaches. There's ego state therapy. Gestalt therapy addresses it as well. There's so many different ways of doing it that these two little interventions are actually steps that fit into these full interventions, like, let's say, trauma-focused cognitive behavioral therapy. And so you want to have an idea of what the actual treatment methodology is you're using, as well as have training and or supervision in it. Or else it's just confusing. You might get lost. As you're working with a person, though, and they're trying to work through the narrative of the trauma, there's parts of it that are important in the narrative that they will need to get out. They need to get out not only the event of what happened, but what they feel emotionally, physically, what they think now about the event, what they interpret the world as after the event occurred. All those pieces come into a whole to describe how this has affected them as a person. And helping them to be able to bring everything back together can help them also not only know what are possible triggers in the future, but to also realize, hey, I have the capacity to talk about this and to work through this now and still be okay. I'm uncomfortable, but I can be okay. Okay. Other ideas that this book has that can be helpful. Acknowledge the need to implement anger control techniques. There may not be like an anger or explosive disorder or a personality disorder present, but anger may be the way that they deal with it. And so that's the short-term goal. The techniques might be teach the client anger management techniques, or assess the client for instances of poor anger management and those types of things. And again, it's to bring to their awareness, okay, this is what you feel, this is how you react, let's come up with other things. And another actual one is report increased comfort and ability to talk and or think about the traumatic incident without emotional turmoil. So this comes with more as you're moving towards finishing up with the trauma narrative. As you're working with the individual, you can come up with a means of scoring or labeling how they feel they're progressing in the treatment. It could be just simply a scale of 1 to 10 on how comfortable they are thinking about it or talking about it. Or it could be something else you come up with. But ultimately, with the goal with this client, so again, this is just one book, one idea. If I were working with this client, again, I would start off with probably 3 short-term goals, just to come off my top of my head. The first would be for the client to feel comfortable in his own skin so that he can actually carry out day-to-day activities. So that would be kind of like an idea for the short-term objective. But the interventions I would use, particularly with this client, would be physical interventions. He was a very physical person as it was. He liked to work with his hands. He liked to be outside and be involved in things like that. And so we would come up with activities or things he could do while staying focused on calming his nerves. I remember doing breathing exercises with him that actually didn't help because that required a certain sense of focus. He couldn't do that very well. But what he could do was go out in his garage and work with his hands on a motorcycle or something like that. And again, the goal was to teach him so that he could learn and understand that, hey, I can be okay in spite of these feelings and these thoughts that are intrusive that I'm experiencing. And so we might work on that for a couple of sessions. The second objective would be what I would call trauma resolution. And trauma resolution would be that they are no longer feel extreme discomfort with what happened with the trauma memory, that they are able to achieve some kind of acceptance of what had happened and who they are after it happened, and that there is a decrease in symptoms. And that's where those specific methods come into play that I mentioned a few minutes ago. So with him, I might use EMDR as one, and EMDR actually has its own steps within it, or I might use a narrative type therapy approach with him, which also has its own steps. I would use what's going to work with him because, like, for example, EMDR doesn't work with everybody. I've had clients where it did work, did a good job, and it met those goals, those 3 objectives I just defined. But I've also had some where it just didn't do anything. I've also had clients where visualization, which is what EMDR involves, they couldn't do that. And so we had to come up with other things, such as doing sand tray therapy or art therapy. Again, these are all things you guys will learn over time. Nobody's expecting you to know all these things as you're moving through grad school. This is just stuff you've got a long career ahead of you to learn these things. So that's the second objective, trauma resolution. And the third one I would call reconnection. And these are words that I didn't make these up. These come from actual methodologies. But reconnection means that a person has finally gotten to the point where their symptoms are calm enough and they have a sense of being okay to where they can function in society and in relationships. And so with him, it might simply be the objective is for the client to find and achieve a new career path or a new job that he's happy with that will meet his needs. Because he wasn't happy at that point. And then with his relationships, he still had family members that he would be able to reconnect with those family members and feel comfortable with them and no longer feel the guilt that he had. And when it comes to the actual interventions, a lot of that would boil down to just planning, helping him do some career type counseling, maybe even connecting him with a local job agency rather than just a temp agency, and helping him see if what he wants to do for the rest of his life. Then when it comes to relationships, that I would probably say would involve more along the lines of doing a person-centered or existential approach, something humanistic. to help him explore those feelings and those feelings of feeling like a failure so that he can actually engage in relationships. And the goal also, and this is part of goals, is you always want to have a time period. Your goal is to be done with this by the end of 12 sessions, 20 sessions, whatever it is. With somebody who has something that's pretty severe, like this client, it's going to take a while. It's not going to be the normal, if you want to call it normal, somebody coming in for sudden life changes and difficulties that have led to depression or anxiety, and you're helping them just work through it and gain the skills so that they can move on and continue with life. This is a bit bigger because this involved a huge loss. So be patient. Another aspect of finally implementing the interventions in the treatment plan, and I would say this to anybody, regardless of what level they're at in their program or in their career, do not work harder than your client. If your client is struggling with one step or one of the objectives, that's okay. That just means there's possible resistance going on or discomfort. And so at that point, your treatment goal is no longer working on that objective. It's working on the resistance and the discomfort, which is hindering them from moving forward. And so it all becomes part of it. And you will have those clients where things just aren't moving forward quickly. With this fella, I thought I'd be done in 6 months, and I wasn't, because new things kept popping up. He had a history that was just full of other issues that were that came to light as we were working through it, that were causing problems. And that happens too, though it doesn't happen as often as working with someone who's there for depression or anxiety. Another thing that I would say too is, when it comes to these treatment plans, be flexible with them. Be willing to change them if time goes on, or to adjust them. Just because it's been written down doesn't mean it has to stay. Like a case conceptualization or an assessment, it can be fluid. It can change when needed. And so today I planned for just a short discussion. I'll have obviously more discussions in the weeks to come, but that is what I have on treatment planning and on utilizing interventions. But I'd like to, if you guys want to, and I'll open up the chat for you, what questions do you have about treatment planning or interventions that we could go over right now, if you have anything at all? Okay, some people are typing. I like that. Thinking. What it needs is that cursor that just sits there and turns, that icon. It says people are typing. So we'll wait. All right, so this first one: for my mock counseling sessions, my client is dealing with work stress and looking to obtain coping skills. She has great stress reducing techniques already, and I'm just a little confused on how to structure my session tomorrow. Okay? And then, have you used long-term exposure in your practice? So I'll answer the first one. It's awesome. When clients already come to your office and they have already a great way to cope, that is already a huge part of your battle that's taken care of. So let's first off talk about coping skills. Many of us come into the field with this idea that our clients just need coping skills. Coping skills are good for one thing that I see, and you can take this or leave it. Coping skills get you from this minute to 10 minutes from now. People's feelings and thoughts don't stay the same. They're always changing, especially if they're in turmoil. And if they're experiencing consistent work stress, like for example, this client, there probably is consistent turmoil while they're at work. Coping skills help them to get from day to day. However, the underlying issue, whatever that is, if it's thought processes, fears of failure, feelings of not doing good enough, poor self-worth, or whatever the case may be that's underneath, that's not addressed by coping skills. So again, coping skills gets you from Monday, 9 a.m. to 5 p.m. And then they can use some coping skills while they're at work or maybe at home. But that underlying problem is still there. So I guess what my thoughts are on this are, what are the main issues? What's going on at work? Now, is it supervisor problems? Is it workload problems? Everybody has those. But what's underneath that? And that's what my focus would become. Does that make sense? And is that helpful? And by the way, thank you. That's an excellent question. And this comes up all the time. She's a supervisor with a lack of workers due to budget cuts. So she's overworked. Yeah. Then what you do is you look underneath that feeling of being overwhelmed and overworked. What does it mean? Does it mean she doesn't feel she's capable of it? Does it just mean she's going to be tired for a short amount of time? Does it mean she needs to learn how to let some things go? Again, it's always that underlying thing. Is that helpful? Yes? No? What you're looking for with clients are those moments where they have the aha moments, the light turns on, and they go, okay, this is what it is, and I can do this. I'm capable. I don't want to do it, but I can do it. Oh, good. Good. I'm glad that's helpful. And then the other one, have you used long-term exposure in your practice? So are you talking about like systematic desensitization, long-term exposure? For like, let's say somebody who's been through trauma or has phobias or things like that. I just want to make sure I understand. Yeah, cool. Yeah, I have. It depends on the situation. I wouldn't use it with everybody. I'll give one example of how I used it with actually a child. There was a child I was working with. She was 5 years old, 4 years old. She's pretty little. She went outside one day. Her neighbor's dog was outside just walking around, and for no reason whatsoever, nobody understood why, the dog attacked and bit her. Actually bit her right here in the face. She ended up having to get stitches right here. And she was pretty shaken up by it. Not only was she afraid of dogs after that point, but she was also afraid of anything with fur. Anything. Everything. So, because she was young, and also I did this with her parents, so they were in with it and worked with me with it, we decided to do a systematic process with her of desensitizing her to the idea of being around a dog. So the long-term goal was that she would be okay and comfortable being around animals, dogs, things with fur. But we needed those step-by-step things. So the first goal we did was we drew pictures. We drew pictures of dogs, of cats, of bunnies, of pretty much anything. She gave them names. We played games with the idea of these animals. We told stories. We talked about them being furry. And then we continued to do that for 2 or 3 sessions. After that, we moved into not just talking about the animals, but what they feel like when you touch them. Then it moved all the way to the point to where we introduced a teddy bear to her. Then her parents, and I requested this of them, took her to a store and she picked out her own stuffy, her own animal. And then finally it got to the point to where she was petting cats and finally a dog. And just by happens chance, we had a dog in our office. It was a little poodle, so it was pretty small and unassuming and very, very good to be pet. And so it took, I think it was about 8 sessions. So yes, I have done that. With this particular client that we've been talking about, no, I would never have done that with him. The things that he needed, that he would have had to have been exposed to, were too severe. Now, if it had been like an accident where he had been the recipient of an accident, an industrial accident at work, I would possibly go that route. But where it was his son and he had died, no. That was it would have been very inappropriate and just wouldn't work. Does that answer your question? Excellent. Any other questions or thoughts about treatment planning, interventions, and putting them into play? Or any thoughts? Document the developments. Okay. Are you talking about the actual, like what happens every session? You talking about doing like a DAP note or a SOAP note? And then another one, when would you introduce the intervention? At what point in the session, or should it happen in the beginning? I start talking about interventions at the end of probably the first session, or the beginning of the second. And then documenting it. Again, it all boils down to the type of note you're going to use. For example, I think I've got an example of one right here that I can share with you guys. Let's get rid of that. Where's that? And progress note. Okay. Not the progress, but about where to write new interventions or directions toward treatment. You actually write it in. You just write it into your actual client progress note, or you add it as an addendum to your treatment plan. The most important part is that you have it documented. That's the most important piece. If it's in your client progress note, like for example, this is called a SIP plan, where you've got the situation or symptoms, the intervention that you use, and the plan. I would probably put in the plan that there's been an addition to the treatment plan. This is the plan. This is how it will be done or added to it. It just has to be in the case file. Does that answer the question? At least well enough? Okay, good. The important thing is to document. Just make sure you have a note of it written down somewhere in the file. Most of the time, you'll never pass that file on to somebody else, and I believe you're required by law to keep them for anywhere from 7 to 10 years. But if it does get passed on, again, you'll have that conversation with whoever takes over. Any other questions? Okay, I will take that as a no. So far, again, I'm just going to sum up: case conceptualization, using assessments, diagnosis, now treatment plan, now putting in the interventions. I have a whole other list of things that we can continue going over. Again, we'll do this again in 2 weeks. And I'm trying to set it up in a way where it's just intuitively step by step. But at some point it won't be. And I've got a whole bunch of other stuff. But thank you guys again for showing up. If you talk to any other students online, tell them about it. I think this can host quite a few more and be happy to. And also I'll leave the recordings open for everybody. Okie doke.